Sensationnel.
Most people think that introducing the TE probe is very difficult. But if you follow the tips and tricks we gave you in the previous lecture, and with a little bit of experience, you will find it quite easy. Okay, now we have the probe in place. But what is the next step? Bruno will show us. When we're inside with the probe, we have to look for something. What do we look for?
The first thing I'm looking for is naturally something that moves, and beating heart, for example.
Good.
Yeah. And there are some movements that we can perform to do it. One of the first movements is to push in the probe into the patient, and we can reach the deepest region of the esophagus and of the stomach. Okay. Another movement is to pull outside the probe, something like this, and you can go higher and higher to the aortic arch, for example. Then you can rotate the probe on the left side or on the right side to visualize better the right or left heart structures. Mm-hmm. And I would suggest always to stretch the probe, like now.
Why is that so important?
This is very important because you need less strength to reach your views. That's
so it's the motion translates better to the tip of the transducer if the probe is stretched.
Exactly.
A very important point.
So, if we see on the monitor, for example, we can see a four-chamber view. We look for the four-chamber view, and we see if I stretch the probe in this position with a small rotation on the left side, I will see better the left atria and the left ventricle. Then I go back. If the probe is not stretched, it's very difficult. I haven't almost any movement on the image. Instead of, I have to move a lot the probe. So please stretch the probe.
Good. And coming back to the heart, now that we have the four-chamber view, can you just show us what happens if you perform those different maneuvers you just showed us?
Yeah. We can see as soon as I am on the heart image, on the four-chamber view, I can change, for example, the angle of the image. I can move from 0 degrees, like at the moment on the monitor, to 180 degrees.
So basically what is happening here is that on the tip of the transducer you have a mechanism that turns the transducer 180 degrees, so you can kind of scan the entire heart. And that is what you see here on the screen. So we're scanning through the heart, starting from a four-chamber view. So the one motion is pushing the probe in and out. Can you show that again, what happens? Okay. The second is to twist the probe either to the left or to the right, maybe showing it from the ventricle, that you see what happens with the ventricle, right? And the third motion that we showed you here is rotating the probe, okay? And then there's
angle.
Exactly, the angle. And then there's one additional way of manipulating the probe, and that is done with these wheels here.
So we have two wheels on our adult transesophageal probe. For the children, sometimes it's only one wheel. The two wheels allowed us to perform through this movement.
Can you show here, maybe let's see what happens with the orientation of the probe when we do this?
So when we are on the four-chamber view, for example, if I perform an anteflexion like this, I will look up and I will reach the aortic valve in something like a short axis view. If I perform a retroflexion like this, I will catch the maximal length of the left ventricle. But it's important that I am sure to be on the right plane, because of if I am too deep or too high, I will not reach the standard views that I'm looking for.
I think this is the reason that I personally use these wheels is in some patients you have an axis that will give you a kind of a very strongly foreshortened four-chamber view. And you can extend the length of the ventricle. This is exactly what Bruno is doing now. You see the four-chamber view gets much longer and you see more of the apex. This occurs because you're now retroflecting the probe and you have an angle which is better aligned with the axis of the heart. So this is where you could use this. And another reason to use it is if you lose contact with the esophagus, you can sometimes, by manipulating these wheels, get a better contact to the esophagus, and then you have a better view altogether and a better image quality. So this is where I use the wheels. And then, of course, for the transgastric views, but we'll show you that later.
The four-chamber view, a very familiar cut plane if you perform echocardiography. Most of you who perform transesophageal echocardiography already know it.
So, Bruno, which view would you start your examination with?
I look for the four-chamber view, always like my first image, because this is the reference image for my transesophageal examination. Now, in the monitor, we see the four-chamber view. Four-chamber because there are 4 different holes. As you can see in this image, the 4 holes, we are very close to the probe, the 2 arteries, and on the distal side there are the 2 ventricles.
Yes, and when we compare our echo image to the anatomical image, we can really see that the probe stays inside, stays behind the left atrium, and this is the reason why we have such a terrific quality, and also the reason why the first images are, the first cavity we see are the atria. So actually we can really well visualize tricuspid and mitral valve. We see the left side of the heart, the right side, and what can we do actually to optimize these views when they are not so clear?
There are 2 important changes that we can do in our settings of the probe for the four-chamber view. The first of them is the retroflexion of the probe, like this. This will allow us to reach the longest image of the left ventricle. And this is important to measure the diameter of the left ventricle. The second important things to do, especially in patients with ascending aorta pathologies, where the right heart valve is very difficult to see, I would suggest to change the angle from 0 degrees till 15 or 20 degrees. And we will reach so an image where it's very easy to see the tricuspidal valve.
Without the aorta.
Without the aorta.
No wonder we love this view. It gives us just so much information. The mitral valve here is nicely visible. The left ventricle, we can look at function here. Parts of the right ventricle are seen here, the interventricular septum, and obviously it's a view that is easy to interpret. One of many examples of pathologies that you can visualize in this view, a patient with mitral stenosis. Clearly we have doming of the anterior leaflet. From the four-chamber view, it's easy to get to the next important view, the five-chamber view. All you need to do is retrieve the probe a little. Let's see how Bruno does it.
The five-chamber view is one of the new standard views of the new guidelines for transesophageal echocardiography. We know the five-chamber view from the transthoracic examination, and in the transesophageal examination is not very difficult to get.
What do you do actually?
The only movement that you have to do to get it is to pull out the probe. How much? A little bit, half centimeter, 1 centimeter, not more, not more. As you see in our monitor, you can see without changing the retroflexion, without changing the angle that we put before, I have only to pull out the probe, and obviously in the middle will come a structure. This is the aortic valve.
And we are actually performing an oblique cut of the aortic valve, so actually the aorta is coming towards us.
Exactly. If you see, when I pull out the probe again, you will see the aortic valve and then the ascending aorta till the aortic heart.
It's extremely nice to see also the anatomical relationship.
Yeah, but you know very well that this couldn't happen in the normal transesophageal echocardiography because of the trachea.
Yeah, we miss a small part of the ascending aorta actually.
What is the 5-chamber good for? We can study aortic valve pathologies, look at aortic regurgitation, even though, as you will later find out, there's a view where this is easier to perform. We can see the left ventricular outflow tract. We can see part of the ascending aorta. And we can also study the mitral valve, especially the anterolateral portions of the valve. And finally, the intervalvular fibrosa is a structure which can nicely be studied with the help of the 5-chamber view. Here's an example of a patient who has mild to moderate left ventricular dysfunction. And here we can see the aorta nicely here and the outflow tract. As mentioned, this would be the anterolateral portion of the mitral valve. In contrast, this patient definitely has hyperdynamic left ventricular function. Again, we have the aortic valve here. This is the LVOT. And what we see here is a very awkward motion of the mitral valve. It's performing a motion we call SAM, where during systole, this valve or the anterior leaflet is kind of pulled or pushed to the interventricular septum, thereby causing occlusion of the LVOT. This is exactly one of the views where this can be visualized very, very nicely. And this is very important for anesthesiologists, for example, in patients who are hypovolemic and who have maybe too much catecholamines on board. So far, we've only seen views that we know from transthoracic echocardiography. Anna wants to learn something new. Can Bruno show us?
So till now, actually, we've seen views we can also get with a transthoracic examination. Bruno, can you show me something new?
Nah, it's a pity because the next views, the next images are not very new because of these are the old 20 standard views that we have seen, but they are very, very important. And I have some tricks for you.
Super.
So, the next image is the middle esophageal long axis view. From the 4-chamber view, after retroflexion and after the changing of the angle to something like 120 till 130 degrees, we will reach this image as we see on our screen. Sometimes this image is called a 3-chamber view because of you have 3 very important structures on it: the left atria, the left ventricle, and naturally the aortic valve.
The aorta. And yes, it's really nice to see the correlation with anatomy, and we can also, can we get also a little bit more of the ascending aorta in this view?
Yeah, there is no problem. If we see the aortic valve here on the left side of the monitor, I try to put a little bit inside the probe and I can perform an anteflexion instead of the retroflexion to have a better look on the aorta.
And here we are also looking at different segments of the myocardium. And what I think in this view is really important is to focus on the mitral valve. This view will be extremely useful when you want to assess mitral regurgitation as well as endocarditis and look for vegetation on the two main valves actually we have, aorta and mitral.
Exactly, exactly. If you see here, you can see the first part of the ascending aorta on the monitor exactly in the middle of it. If you perform a small anteflexion, you will get much better the aorta on your monitor, and you lose all the heart structure like the aortic valve.
When you want to focus on the ascending aorta.
Exactly.
You are right, Bruno, this is not a new view, but for sure it's a lot of information and totally useful.
The apical long axis view is actually one of my favorite views because it's easy to get and provides a lot of information. Here's such a beautiful view in a normal individual. What can you see? We can study aortic valve pathologies. Now, this is the view that I would use if I want to assess the severity of aortic regurgitation. We can look at the LVOT, similar to the 5-chamber view, but probably even better. We can look at different portions of the myocardium, especially the posterior lateral wall and the anterior septum. And finally, we can also look at the mitral valve. This view would be the ideal position to look at, for example, placement of a mitral clip during the mitral clip procedure. The advantages of the apical long axis view are highlighted in this example. We see two pathologies. Again, we have a SAM, in other words, a systolic anterior motion of the mitral valve. You see how the mitral valve is now occluding the LVOT. And the second thing is we see a vegetation or thickening of the aortic valve. In other words, this patient has endocarditis. Two different pathologies which can be seen in this specific view. Bruno has shown us some very important standard views, but I think Anna is now eager to show us something too.
Okay, now Anna, I will show you another view, the two-chamber view, middle esophageal two-chamber view.
Wait, Bruno, can you give me the transducer? Because this is really a view that we cardiologists like. I will show you why and how to get to this view. So actually, when you have optimized your 4-chamber view, you only need to play with the degrees. So actually, I will add degree to my image and reach around 80 or 90 degree. So this would be a nice two-chamber view. As you see, you can compare the echo image to the anatomical image we have on the same screen. And this view is extremely important because first we see different segments of the myocardium. We still see the left atrium, and we really have a focus on the mitral valve.
And how you can see here, the left ventricle, we have two walls. On the right side of the screen, you see the anterior wall, and on the left side of the screen, you see the inferior wall. And here you see this small vessel, and this is the sinus coronarius. This could be very interesting. And do you know, there is a new standard image that probably you know very, very well, like a cardiologist.
You mean, I think, to optimize this view to see the left atrial appendage better.
Exactly. There is a new view, the middle esophageal left atrial appendage view, that allowed us to see the left atria auricular. It's very important for the diagnosis of thrombus.
Yeah. For us, this is not a new view, it's an old view, and it's only one of the views actually you can use to visualize the left appendage, and this will be extremely useful when you want to look for thrombi, for instance, in the left atrium.
How do you reach this image?
Well, actually, sometimes you just go on with the degrees till 90 and you can really see it clearly. Sometimes you have to adjust your image. So what I do, I usually put the the probe a little bit higher. So I pull it out a bit and I play with the depth because I want to reduce it to really see the atrium and left appendage. So Bruno, I can see that actually cardiologists and anesthesiologists talk the same language when it's about echo.
So the two-chamber view shows us different portions of the heart. We see the inferior part of the ventricle here and the anterior part here. And we also see the left atrial appendage. You see that the left atrial appendage is always in close proximity to the anterior wall. So a very important view to study regional wall motion abnormalities and also to assess mitral regurgitation. The next view we're going to show you is not far away from the two-chamber view.
Then, Anna, can you give me the probe? I would like to show a new image.
Well, which one, Bruno? Of course, here's the probe.
I thought from the two-chamber view it's very easy to go in the middle esophageal commissural mitral view. If you don't move the retroflexion that we catch before, we have only to change a little bit the angle. We need something about 60-80 degrees. That means I go back with my angle button and I will catch an image like this one.
Okay, so this is the image actually we very well know. It's the image to visualize commissure. So we have on the right part of our screen the anterolateral commission and exactly on the other side the posteromedial commissure. And this is, I think, really good when we have mitral regurgitation and we want really to assess where the jet comes from.
Yeah, this is an image that allowed you to see other possible direction of the jets, and that's why you have some advantages to get it during an NT examination for a patient with mitral valve pathologies.
And I'll tell you more, this is an extremely important view to follow surgical and percutaneous procedures, for instance, like the mitral clip procedure.
Anna is right. In the commissural view, we're cutting exactly along the line of closure. In other words, we're able to detect the region or the origin of mitral regurgitation. Let's take a look at this image here. What you see here is the commissural view, and in such a view, it's not possible to discern between an anterior and a posterior leaflet anymore. We see a valve plane moving back and forth. When you have this in your field of view, you know you're in the commissural region. In this view, one can often also see the left atrial appendage right here. So this is an additional advantage of the commissural view. Anna and Bruno have shown you some views. I think now it's my turn to show you something.
I would like to show you one of my favorite views and a very important view for us cardiologists, the so-called bicaval view.
Ah, okay.
But
This is
you know
very
this view,
important
right?
for us too.
Why, Bruno?
We need, during a special mini-invasive cardiac surgical procedure for the reconstruction of a mitral valve or substitution of the mitral valve, we need to see the cannulation in the two cavas.
Right. So this is the advantage of this bicaval view. We see both vena cava. That's why it's called bicaval view. But how do we get to this view? There's two ways that you can use. The one is that you bring the right heart into the center of the image. Remember, when you rotate, both in transthoracic and transesophageal echo, you always rotate around the middle of the sector. And then you would change the degrees slowly until you reach a point where you are somewhere between maybe 100, 120 degrees. Yeah, maybe a little bit less here. And sometimes you need to pull out a little bit. Yeah. You play around until you finally have both cava, the superior and the inferior cava, in your field of view. I think the anatomy on the right here shows very nicely that actually the inferior and the superior vena cava enter the right atrium along pretty much a straight line. And the right atrium is connected to this line like a bag. And here on the right side, you would now have the superior vena cava. And here you would, for example, see pathologies a tumor that grows into the heart, or even more frequent, a central line catheter that has a thrombus or vegetation. An important view because we do not see this superior vena cava very nicely on the transthoracic echo. So we have a little bit of blind spot there, and that helps us, the TE helps us to see that. And the other thing we see here very nicely is the intraatrial septum. The intraatrial septum is an important structure, and when we perform transesophageal echo in the cardiologic echo lab, we would be looking, for example, for a patent foramen ovale here. So this is the view that we would get. And then there is another way how you could get to the bicaval view. And that is if you start from an apical or from a three-chamber view. Remember, this is the view where you see the aorta very nicely. Okay, this would be such a view. And then from this view, you would rotate the probe a little bit more to the right, and then you would get the intraatrial septum, and all you have to do then is adjust the angles a little bit until you get the bicaval view. Okay, so again, the bicaval view. Let me name the structures. You have the superior vena cava, the intraatrial septum, the right atrium, and here you would have, if you play around a little bit more of the, let me see here, the inferior vena cava, right here it is. So you see, there are many ways that lead to a bicaval view, just as there are many ways that lead to Rome, even from Naples, right, Bruno?
Yeah, exactly, exactly.
Okay.
The bicaval view is an important view for cardiologists and anesthesiologists alike. Here's an example. What can we see? Well, we have the SVC here, the IVC here, and this is the intraatrial septum. And clearly, this will be an important view if you want to see the inflow of blood into the right atrium, and if you want to see if there's a communication between the left and the right atrium. Specific structures need specific views, and for the aortic valve, there's one view that I would really recommend.
The aortic valve is an extremely important structure, and with the help of TE, we can get a lot of information we can't get with transthoracic echo, and often we have to turn to TE to detect certain pathologies. Bruno is now going to show us how we can get a good view of the aorta starting from a mid-esophageal view, in other words, a four-chamber view.
Okay, let's see the aortic valve. We have exactly two important views in mid-esophageal sector to watch the aortic valve. One is the middle esophageal aortic valve short axis view, and the second one is the middle esophageal aortic valve long axis view. Let's get the valve. From four-chamber view, we have to perform three important movements. Pull out the probe till you are in five-chamber view. Anteflexion of the big wheel, change of the angle from 0 degrees to about 40, 50 degrees.
Mm-hmm. Okay, and so this would be the view where we'll be looking for the three cusps, but Bruno, something is wrong here.
It doesn't look like a normal.
Yeah, this is kind of strange, Bruno. What could it be? What could it be?
This is a typical endocarditis of the aortic valve. We can see a very fat leaflet. All the three leaflets are very fat, and probably let's give a look on the middle esophageal aortic valve long axis view. Probably we will get more information.
Yeah, see, if you have a pathology, obviously you're not going to look at the pathology only in one view, but in two views or three views. And therefore, we're going to now switch back to a view you've already learned before, which is called the long axis view. And here, I think you'll agree, we see vegetations on the valve.
It's for sure a vegetation. We changed the angle from 40 degrees to 120, 130 degrees to catch this aortic valve long axis view, and you can see very nice the pathology of the valve.
Yes, but now we have to go back and show our audience a normal aortic valve as well. So I'll just switch now to the normal aortic valve.
From four-chamber view, pull out the probe, gentle anteflexion of the probe, and angle to 40, 50 degrees circa.
Now this is beautiful. You just advance and put the probe further in until you get the 3 cusps of the aortic valve. This is beautiful. Now you see that we have the 3 cusps, the peace sign as we call it, or the Mercedes star. We can identify the 3 different cusps here. We have the acoronary cusp, we have the left coronary cusp, and the right coronary cusp. And if you play around a bit, you can even see the ostia of the coronary arteries. You see, if you correspond this here with the anatomic image, you will realize that right down here is the left coronary artery, right? See, it passes close to the left atrial appendage right here. And then here you would have the right coronary ostium. So, beautiful view to look at the aortic valve and the aortic sinus.
I have to say that in the traditional transesophageal echocardiography, it's very easy to find the left coronary ostia, but it's very difficult to see the right coronary ostia.
Yeah, it's usually much more difficult. Yeah. But to summarize, start with a 4-chamber view, retrieve the probe, anteflex, put the aorta in the center of the image, and then rotate somewhere around 30, 35 degrees, depending on the anatomy of the heart, and then you'll get the aortic valve.
I guess with this view, you now better understand the anatomy of the aortic valve and also how to detect the pathology, for example, as endocarditis. But I want to show you a few more pathologies that you can see in this view. Again, for review purposes, this is the aortic valve. And if we look in more detail, we can even see, as already mentioned in the demonstration, the coronary artery. Right here would be the left coronary artery. An example of a patient who has a bicuspid valve. We see there are actually 3 cusps, but 2 cusps are kind of fused here. So we have what we call a functional bicuspid valve. And here's an example of a pathology you don't want to have. A patient who has aortic valve prosthesis. You see the metallic substance or the metallic valve here with artifacts. And surrounding the prosthesis, we have a thickened aortic root, which is a perivalvular abscess. If you retrieve the probe just a little bit and change the angulation, you will see the left atrial appendage right here. This is very important because there you will be looking for thrombi. This is, as a matter of fact, one of the most frequent indications for a TE study, at least in our lab, looking for thrombi in the left atrial appendage. As already mentioned, this left atrial appendage is free, but certainly not this one here. It's easy to see that this patient has a very large thrombus which protrudes out of this left atrial appendage and is almost peeking towards the mitral valve. A scary finding, actually. TEE not only helps us in the assessment of the left heart, but also in other heart structures. Now, let's take a look at which views we need to look at other parts of the heart.
To assess the right heart, we will use a special view, which is called the inflow-outflow view. Bruno, please show us. How do we do it?
Okay, Thomas, it's not a difficult view to get. You have to go in the 4-chamber view. So then make some retroflexion of the probe. And after this, you have to turn the probe to the right side so that the atria and the ventricle are exactly in the middle of our ultrasound sector. Then you have only to change with the same retroflexion the angle to something about 60 till 80 degrees. Normally with 70-75 degrees we reach the right ventricular inflow-outflow view. And now we are exactly in this view. As you can see, there are a lot of information about the right heart. You have information about the atria, the right ventricle, and naturally the valves are included too, tricuspidal and pulmonary valve.
Right. This is a view you've all seen before when we did the transthoracic echo. This is nothing else than a short axis view at the base where we have the aorta as the central structure, and then we have the right atrium, the tricuspid valve, the right ventricular outflow tract, and then we can also see the pulmonic artery, the pulmonary artery and the pulmonic valve. Now, this is a view where we can study, for example,
we can study the aortic root, for example, and we can study the atrial septum too. And I find very nice to study the pulmonary hypertension. I have to say that I performed the study of the gradient on the tricuspid valve only in this view and not in the four-chamber view.
Good point. This is the preferred view to quantify the velocity of the TR jet. Of course, if you come from cardiology, you always prefer a transthoracic echo than a transesophageal echo, but if you have a TE, this is where I would go. So again, a view that gives you a lot of information and which is extremely helpful. If you perform this view, I'm sure you will be a better cardiologist, better critical care physician, and a better anesthesiologist. Right, Bruno?
Exactly.
And I'm sure all of you want to be good at TE. But now let's take a look at a normal inflow-outflow view. What we see again in the center of the image is the aortic valve. Here is the inflow and here is the outflow. Right here is the pulmonary valve. This view is of course ideal for a number of different features. Here we would look for tricuspid valve pathologies. We could see tricuspid regurgitation and even quantify the degree of pulmonary arterial pressure. We can also look at aortic valve pathologies because remember, that's where we also have the aortic valve right in the center of our image. Furthermore, it's an additional view to the bicaval view to study the interatrial septum, and that's the view that I would be looking for if I want to see a pathology on the pulmonary valve.
You might have noticed that most of the views we showed you so far were obtained from an upper or a mid-esophageal position. In the following chapter, we'll advance the probe down even deeper, all the way into the stomach, and show you that we can get additional views from there as well.